Good afternoon. My name is Kent Dix, and I'm founder and CEO of a new company called Life 365. Just a little housekeeping before we get started, kind of odd, but as I came in here today, I was not approached by Jude or Roger to ask why I was here today, so I took that a little bit personal. The other thing is you might see something fairly unsightly within the next 10 or 12 minutes as I run from Joan with her hook to try to stop me from talking, because one of the worst things you can do with me is to give me a microphone. Just a little bit of my background. I'm a native of Arizona, which is fairly rare. I'm also a graduate of Arizona State University. I am very, very fortunate to have recently, with our new venture, to be part of Marianne Guerrera and Carol Poor and Dr. King's organization with BioExcel, which has helped us out immensely to give us our lift. So it's been a very big benefit to us. Again, I said this is my third venture. I'll kind of go into the history of mHealth and the evolution going forward. I don't know where she wanted me to start, so I'll just start. In the beginning, there was man, right? So we'll go from there. So I think most of you probably know about telemedicine or telehealth over the last 10 years or so. We've been framing it into mobile health, and I'm very proud with our last company. You may have heard of it. It's called MedApps. MedApps was built in 2006, sold in July of 2012 to a large company called Alere, a $3 billion company. I became CEO of that division, of the Alere Connect division, and left in January of 2015 and decided, we were very instrumental in helping frame what mobile health is. When we started in 2006, believe it or not, you kids, we didn't have smartphones, we didn't have ACOs, we didn't have accountable care organization, regulatory framework, we didn't have electronic health records that were prevalent or analytic systems. Now, going fast forward to today, I see the last 10 years as being something of efficacy in doing pilots. We had partners like AT&T and Verizon and Qualcomm and Microsoft and Cleveland Clinic, and everybody would rush in and saying, we're going to take care of millions of lives out there, but we'll start with 100, right? And that's where it kind of propagated for the last 8 or 10 years out there. And where I see we're going to nowadays, I see kind of a triple witching that's kind of occurring. I see the next phase going is scalability. Within the next 18 months, at least, I'm going to talk very much from remote monitoring as it occurs and connectivity as it occurs from home and into the electronic health record. As I see by 2018 and 2019, we have a bunch of different things that are occurring. We have the fact that Meaningful Use 3 is going in place and requiring 5% of all data to be generated, patient-generated data. And we have the fact that reimbursement codes are starting to go in as well, and we have the fact that new accountable care organizations are being put out there as well. So the demand is the industry is starting to demand that connectivity be done in a very, very light way to get actionable data into the back end of the electronic health records and into the EMRs. One of our purposes, and I'll say this, is for us to be able to deal, especially with Arizona, to deal with an aging population, a veterans population, the minority, the underserved population, the rural. In about 2010, 2011, I did testify in front of a House subcommittee on Veterans Affairs for rural and highly rural, because we know that, and Roger mentioned some of this as well, we know that when a patient is within 2 to 3 hours away from their doctor, they're going to tend to exacerbate that disease and make it worse, and your next thing is you're going to present in the emergency room. I have to tell you that, I talked about scalability, and I think that's exactly where we need to go. It seems like Joan had a crystal ball when she put Global Med, the great work that Joel and company have done with Global Med, then she put Hamid on stage from the VA, and they're talking about connectivity, and they're talking about large electronic health records and analytic systems. The things where we are today that I realize is that those analytic systems now need to have data, and they need to be able to get it, as we say, across a large population of patients at the most economical cost possible, the large amount of actionable data to try to get the best outcomes and to try to get healthcare costs down. So don't get me wrong, and probably Hamid will say this themselves, doctors don't need to have more and more data out there to analyze, but the analytic systems to be able to do their job and to identify that person needs to. Now this is a very confusing chart, and I meant that on purpose, but when I talk about the 2018-2019, I do see this as an inflection point when ACOs were started, or start kicking in, or reimbursement, or some of the early telehealth systems and mobile health systems that are out there, and then the Internet of Things starting to take off, and then cellular technology starting to do it. I start seeing a ramp that's going to start occurring in the 2018 and 2019 timeframe. People that are financially responsible for the patient need to be able to be connected to that patient lightly, to be able to see if they're going to be heading towards the emergency room or not, and we need to think creatively on how we do that. So some of the things that you've seen out there, and I think probably the VA has experienced this over the years as well, is traditional legacy systems that are very heavy to deploy, scales and blood pressure devices. When we came into the marketplace, there was traditional systems like Philips and Honeywell and others that were out there, and they've got newer systems now. This was 10 years ago. They were around $3,000 and expensive per month. We came up with a device that was $300, and it was called the Health Powell, and it had Bluetooth and cellular connectivity to connect this stuff. But we're still shipping 20 pounds worth of equipment. So we think that we could probably get to about 10% of the marketplace of those 20% that consume 80%. And the new thing that we see with Light 365 going forward, and the solution that we call Rain, is the fact that we need light, little technology. I know, I have a crystal ball, I know within the next 3 to 5 years that medical devices as we know them, blood pressure, pulse oximeters, even weight, is going to be done at the wrist or other places around the body, right? Because we're going to have smart sensors, we're going to have smart algorithms, and it's going to be connected to big data analytics in the cloud. I know that medical devices like INR devices with strips, that immunoassay technology, that technology is going to go into the strip, and the device is going to go away. So imagine in the next 3 to 5 years, the platform we're building is the fact that all these sensors that are coming out, the little microfluidic sensors, the immunoassay sensors, can be connected to a light technology and send the data into the back-end system. Imagine letting somebody out of the hospital with congestive heart failure on a readmit issue and send them home with a band and a box of disposables. It starts changing the game. It starts changing the ability, so how you can start scaling. And part of that is Moore's Law, because microchips are getting cheaper and they're getting smaller as well to be able to drive down cost. I know also that it's predicted by 2019 that people 65 and over, our seniors out there, will start having connected devices or wearing wristbands that are out there. Now, you're seeing a little bit of an evolution. I mean, I don't know how many people in here have bought a Fitbit, and can you find it today? Is it in your drawer? I mean, is it on your wrist? A lot of times it's not nowadays, because it has a certain, I'm not putting Fitbit down anyway, but it has a certain amount of functionality. And that functionality, once you're out of that episodic thing, it doesn't provide you any other functionality. It needs to be bidirectional, and that's kind of the stuff that we're looking at doing, and we are doing in this. The Fitbit marketplace and the smart watches is about a $5 billion market. They have a growth rate of about 3%, 3.4%, about 70 companies over there. The mobile health and wellness market space through 2020 is a $49 billion space with a growth rate of 33.5%. So we need to take the technology, somebody tackle Joan, by the way. We need to take the technology that's in the tracker and watch space, and we need to move it over into the senior space and be smart about it to be able to do that. It has to be self-directed. We are building a portal where the family can go into the portal and help control mom and dad. My mom and dad that live in Ottumwa, Iowa, I can actually go through and have, mom has the band, it has fall detection on it, has the ability to do medication adherence. If we want to do vital signs, we can do that. We have a new little feature which is called Nudge. You can go on the iPhone, you just touch it, and it sends a love bite to mom to say, I'm thinking about you. So it keeps that band on the wrist longer to be able to do that. It creates the family connection better with this. She has a willing and a need to live. So the band is going to be an icon-driven band that we're making. It goes to the cloud to the system called Rain. It's not a big, invention. It's cloud-based technology, Rain, droplets, pools of data, streams, right? That's what the system's called. And then it goes back into the back-end EMRs and EHRs. I used to have to store data, right? I used to have to go through FDA because of alerting and everything else was there. Those analytic systems exist nowadays. Those back ends exist nowadays. We need to integrate the data into that clinical workflow. And then we drive it by a solution that we call personalize. There's a lot of analytic systems out there that are clinical support and predictive analytic systems. They're great. We need to feed Hamid's system. But we need to drive an analytic system called the engagement analytics. We need to go through and say, what really engages Kent, right? We use a model called I am human, so I engage me on me. So giving my mom a silver sneakers membership when she walks 200 steps a day is not an engagement. She doesn't see that for taking her medication. But giving her a Netflix subscription, there's an engagement that she can get herself around. Now, it's a little counterintuitive because she's sitting in front of the TV and you want her to get out, but she's not going to walk more than 200 steps a day. And she's going to value that relation, that whatever I gave her, right, from that perspective, whatever values on her terms. And she's going to achieve staying out of the hospital, better outcomes, reducing healthcare costs. That's the objective with Mom, going forward. So we want to build clouds that are out there in the middle. There's clouds that we can put together, and for messaging, there's droplets. They're for medication adherence from people that are already out there. I call them a lot of shiny objects that have been connected in the last 10 years or created in the last 10 years. There's probably 150,000 apps that have been created for iTunes and iPhones, and they get downloaded once and they never get downloaded again. So how do we take those shiny objects and how do we put them so they can be downloaded to your Fitbit-like band to be able to keep Mom compliant and get the data into the analytics system and keep her out of the hospital to do that? So I'm going to wrap up here in a second, Joan, but my biggest thing you'll see from this is one solution doesn't fit all, right? If we approach healthcare from the standpoint that you must do it my way, right, from the personalized side, you're going to fail. If you approach it from the standpoint that one solution fits all, you're going to fail, right, from that stand. So you're going to see people, a certain amount can be used Fitbits, and that can be used, Fitbits in over 80 clinical trials right now, from obesity to heart programs to other programs that are out there on steps and sleeps and calories. They have the Silver Sneakers program, which can move the needle a little bit with people that are willing to go to the gym. But, Silver Sneakers, and we have, Patrick Yount, who's our CFO and COO now. He came from the Silver Sneakers program, which sold to Healthways years ago. It's not about getting the elderly out to exercise. It's about the social connection that they make between each other. It's their willingness to live, right, with it as well, that we kind of bring it all together. And then on the other side is their traditional telemedicine solutions and the clinical solutions that you can deploy. But a lot of times they're costly to deploy and the total cost of ownership to get them out with people. Can we meet that gap in the middle, which is between those memberships and those Fitbits and the full clinical systems, and use lightweight technology to be able to do it? And that's what we're proposing we do. So I'm not going to go into all this. The bidirectional communications, it allows Fitbits to get into healthcare and everything. Rapid diagnostics to be able to take near field and touch it to the band and get the data to go to the cloud, and driven by the analytic systems. And some of our initial use cases that we're doing are the Help I Fall and I Can't Get Up, which is more dynamic PERS, point of care rapid diagnostics, remote patient monitoring, medication therapy, and then working with the large self-insured employers on health and fitness, but also working with their working chronic, I call them, people that are still employed but have chronic conditions, and the retirees that are chronic as well. We're initially starting with the B2B2C model, so it's really going out and going after those people that are financially responsible for the patient and trying to move the needle on them. And Joan, that's it. Thank you so much for your time. We do have a booth outside. If you want to talk more, please come see me.